So folks might be joining, a little bit after 12, but I'm going to get started just to honor the time that we have together. My name's Tyler Colbourne. I'm the new professional development consultant with the Nova Scotia College of Social Workers. Today is my 5th day. I know there's some people I know on the attendee list here, so it's nice to see some familiar names and some new ones. But yes, I am filling in the role that was previously held by the brilliant and wonderful Naj. And so that's big shoes to fill. Naj is amazing. I think Naj might be on this call as well. But I'm really grateful and privileged to be at the College of Social Workers and in this role, and I'm really excited. It's also exciting to be doing my first panel or webinar session with folks. So as you probably are aware, we as social workers have professional development hours that we are required to maintain. And this is one of our many initiatives around professional development here at the college. And so this is part of a collaborative care series. And today's session is on how to advocate for collaborative health interventions. Wanted to offer to folks in the chat my email. Reach out at any time. If you're signed up for our newsletter, you might have seen there was a blog post about me in there this week. If you're not signed up for our newsletter, please do. It's really, really great. A reminder that this is being recorded to be made available later on YouTube. If you're not aware of our YouTube channel, we post a lot of our webinars and panel discussions up there for viewing later. And you can just find it at youtube.com/@symbol NSCSW. Yeah, we're going to get started with a land acknowledgement. So I'm going to encourage you folks to join us in the land acknowledgement. So here at the bottom right of your screen, you'll see this website, https://placenames.mapdev.ca, a really great resource. And I invite you to check in the chat. How are you arriving? How are you feeling as we start this call? And if you can, name the land that you're on using the Indigenous place name. So I am here in Chipuktuk on the colonially known as Halifax, on the Halifax side of the harbor, but I live in Punamukutijik, colonially known as Dartmouth. So I want to begin by acknowledging that I am speaking from Mi'kma'ki, which is located on the ancestral and unceded territory of the Mi'kmaq, whose inherent rights were recognized in the peace and friendship treaties that were signed with the Mi'kmaq, Maliseet, and Passamaquoddy peoples from 1725 to 1779. This series of treaties did not surrender Indigenous lands, resources, or sovereignty to the British Empire, but instead established rules for an ongoing relationship between nations. The treaties were later reaffirmed by Canada in Section 35 of the Constitution Act in 1982 and remain active to this day. So inviting you folks to take this time to pause in reflection and gratitude for the land where we live and work. Furthermore, when we acknowledge the land, we must also begin to acknowledge the wisdom of this planet and align ourselves with its truths. So this image here shows a tree stump and a human fingerprint and points to this idea that we are not distinct and separate from nature, but we are expressions of nature. We're expressions of this land. We are not separate from it. And so it's helpful to hold on to that perspective. Let us take a moment to pause in gratitude for all who have and continue to heroically care and advocate for this beautiful land of Mi'kma'ki. May we join them in this sacred work. Let us ground ourselves in the wisdom and the land-based Mi'kmaq teachings and values that we must all begin to learn. Let us work to decolonize ourselves, our practice, and this community that we share by working for justice for all living beings as an expression of our gratitude for being here. Let us take a deep breath and recenter ourselves away from the violent ways colonization fills our world and fills us. Let us take a deep breath and work on letting go of the unconscious bias that is everywhere inside and out. May our session today lead us to be in right relationship with this land and with one another. We are all treaty people. So as a reminder that the treaties that were mentioned in the previous slide don't just apply to Indigenous folks, it applies to settler Canadians like myself. I'm someone of European descent. I'm a settler on this land, and the treaty applies to me. And I think it's important for us to consider, how does this impact what we do and how we do it? How will that guide our work together today and in the future? And also, how do we reconcile the painful history of social work and clinical care for causing colonial harms in the past, and also how it shows up today? Oh, and I see a message from Naj. Thank you so much. So for the College of Social Workers, it's also important to translating the acknowledgement into action. I'm sure many of us have been on calls or been in sessions where someone expresses a short land acknowledgement, and it's helpful to do this, but also more importantly, we have to translate that into action. So for the College of Social Workers, we're committed to translating into action by seeking to implement the recommendations of the Truth and Reconciliations Commission's call to actions. So if you're not familiar with that report and the 92 calls to action, you should check it out. We commit to doing what we can to become better treaty partners. We commit to learning and unlearning. With this in mind, it's helpful to hold an intersectional lens. And so for me, as a settler Canadian who cares a lot about decolonization, one of the values of decolonization is around interconnectedness and understanding that things are quite entangled. And so all oppression is connected. And when we hold an intersectional lens, we can know that there are multiple layers of oppression that happen at multiple points in time. So it's important to hold an intersectional lens in this work. Furthermore, decolonizing ourselves and our practice means recognizing the ways in which we are each impacted by the colonial system in which we all participate, and from which those of us of settler descent continue to benefit. So as a white settler Canadian, I am continuously benefiting from the processes of colonization in the past and in the present. Each of us, depending upon our social location and intersectional positionality, are uniquely impacted and or oppressed. For folks of African descent who were dispossessed and uprooted from their land and brought to Turtle Island against their will, this is also connected to colonization as an expression of white supremacy and the slave trade that fueled the settlement of this continent. So holding and understanding that the processes of colonization are connected and entangled with white supremacy and are parallel forces that are sort of weaving back and forth. So we take this moment to reflect upon the unique impact of colonization upon each of us and upon our practice. Of course, as well, social work understands that public health and safety, as including the psychosocial, the spiritual, the structural, and the ecological determinants of health. And so within the social work practice, many of us are probably familiar with the micro, the meso, and the macro. And then many of us might be familiar with ecological systems theory. I think it can be helpful to take a systemic or a systems theory approach when considering social justice and decolonization, because we can see multiple layers of things and also look for multiple intervention points. Safer patient care happens when we see the whole picture. You might be familiar with this analogy in this image, but on this image, there are many people who are making observations about what they're experiencing. So maybe what they're seeing, they're smelling, they're touching, they're feeling. So it's a wall, it's a rope, it's a tree, it's a snake, it's a spear, it's a fan. When we scale out, we can actually see that it's an elephant. And so acknowledging that sometimes our view and what we can see or experience in front of us is limited. It doesn't show the whole picture. And so as we consider this concept of collaborative care, sometimes we have to collaboratively pull back so we can see the picture together. So again, how can we collaborate together? We're joined by 6 people today. Well, 2 people who are here live and then 4 folks who've pre-recorded content from various areas of clinical care. And so the question we're seeking to answer in this call and in this series is, how can we collaborate better? How can we resist the siloed approaches that are so often present and dominant in clinical spaces, so that we can work in partnership with, recreation therapists, chaplains, and people who offer clinical spiritual care, rec therapists, et cetera, so that essentially we can meet more needs of and more specific needs to our patients and the people we work with, and work towards social justice. So again, this is for how to advocate for collaborative health interventions. I wanted to name that there is the opportunity to ask questions. You can do so in the Q&A box or in the chat. Shortly after this, I'm going to disable the chat for everyone, and so that only the chats that you send will go to myself and the panelists. But I encourage you to ask questions in either the Q&A or in the chat function. We might not be able to get to all the questions, but what I can commit to is using these questions and your contributions towards thinking about future PD activities or content and things that we can share and give back to our members. So if we can't answer all the questions, we'll harvest that information in those conversations and questions to think creatively and critically about what can come next. A reminder, this is part of a series. We've already held a few other sessions, and we have another one coming up on September 17th, I believe. If you're here, you're probably familiar with our professional development initiatives, but I encourage you to look at our Eventbrite, our YouTube channel, and our newsletter for ongoing professional development opportunities. You can also reach out to me at any time if you have questions or ideas. I encourage it and appreciate it. So again, on September 17th, we have our supporting our self-care. So that's around collaboration, conversation, and connection. We also have a session next Friday on the 23rd with George Savory. Encourage you to come to that if you haven't signed up for a lunch and learn. But yeah, we have a whole suite of offerings, and I'm grateful that you're here today, and I hope to see you at future ones as well. Today we're joined by, again, two folks who are live, so you can see Emily and Tara on the call with me. But we also have folks from the Association of Psychologists, the Canadian Association for Spiritual Care, the Nova Scotia Physiotherapy Association, the Nova Scotia Society of Occupational Therapists, and the Nova Scotia Therapeutic Recreation Association. And we have someone from the College of Social Workers as well. So we have 6 clinicians who are offering content today. So thank you to our speakers for joining us today and being part of this collaborative care series. So the speakers will have Natasha Yorke, who's representing psychology, Tara Moore, who's representing physiotherapy, Eva Burrell, who's representing social work, Emily Flynn with recreation therapy, Kirsten Wells, chaplaincy and clinical spiritual care, and then finally Amelia Fletcher from occupational therapy. And so when considering this idea of collaborative care, the questions that are being explored are, what is your profession? You know, for those who don't understand. For some of us on this call, maybe it's the first time you actually have learned about recreation therapy or clinical spiritual care or any one of these. So an offering of like just a little bit of knowledge about the profession in general. And then how can other healthcare clinicians recognize the need for your profession? How, for like myself as a social worker, how can I recognize the need when working with a patient or a client to have a referral to a recreation therapist or someone who needs clinical spiritual care? And then building upon that, how might a clinician make a referral and or work collaboratively with you? And then finally, how can clinicians support advocacy for more of you in your profession? So knowing that we're in a time of mental health crisis and crisis for many patients and clients, how can we advocate for more folks who can offer specific and culturally competent and humble care for people within Mi'kma'ki? So we're going to get started. And the first person that's going to be speaking today is Natasha Yorke. And this is a pre-recorded content. We did test the volume and the sound. It does look like it's working, but if I press this button and people are like, I don't hear anything, Tyler, please send me a message in the chat to the panelists. I'm just going to make some changes here. I've now disabled the chat so that it can't be used for everyone all the time, but please do send me a message if the volume isn't working. I'm going to turn off my volume and I'm going to click this one.
Hey. Thank you for including me in your day. I'm grateful to always be part of any collaboration that's taking place between healthcare professionals here in Nova Scotia. And I'm currently joining you in the beautiful area of Malikia, which means winding and turning in all directions. I'm here in Yarmouth County, and you will hear many things throughout my recording. As I said, I'm at home, so you may hear roosters cock-a-doodle doing, and you may hear dogs barking, and humans making all kinds of noises. So I apologize in advance for any background noise that's happening. I'm Natasha. I am a psychologist working within the school system here in the Tri-County part of the province. And that is one area where you'll find psychologists. Unfortunately, not enough of us. But we do have psychologists. Our profession is kind of a spectrum. You can find us doing all kinds of different things in many different parts of the province. So typically people know that there are psychologists in private practice. And there are psychologists at like hospitals in mental health and addictions facilities and schools, although lesser known that we're here in schools as well. So psychologists are also part of the judicial system. There are parts of our work that you'll see at universities in research. So there's a whole scope of things that psychologists are part of, which means we all have different skill sets. And our skill sets are kind of part of how you specialize throughout your profession and your training. So become a psychologist, obviously you have to go to university, and then you go into a graduate level program specializing in whatever field of psychology you're planning to work in. So if you're going to sports psychology or an operational organizational part of psychology, those are all aspects of ways that you can specialize at the graduate level. One of the pieces that I was asked to kind of get into is, what is the difference between a psychologist and another counselor? And I think that even just in this little introduction, you can hear that there are a number of differences in terms of the aspects of things we do. So counseling is absolutely something psychologists can do. Counseling psychology is a direction that people will go in graduate school. And there's pieces of counseling psychology built into many aspects of how we are trained. But there are also a number of other things that we do. So in my world, most people, I'm trying to constantly convince them that it's not just assessment. So most people see psychologists within the school system and they think, oh, you do ADHD assessments, you do learning assessments and cognitive assessments. And we do, in fact, do those things. And I'll get into a little bit more of that in a moment, but there are a number of things that we can do. So often what we're doing is advocacy work and working on getting people to understand that behavior is a mode of communication. And so we try to support educators and families and all that to understand that when we see behaviors from children, it's often a result of something they're trying to communicate with us about their environment or the circumstances of their world that they need support with. So we do that kind of thing within the school system. But like I said, a lot of people see us as assessors. So there are counselors, there are assessors, but there are a number of people that do other things, like getting into more of the nuanced pieces of, as I said, like a sports psychologist, or perhaps in a prison system doing competency assessments and things like that. So after graduate school, however, psychologists have a board of examiners that kind of oversee our licensing. So that means that after you graduate, there's a number of steps you have to complete. So you have to complete an exam, which is a multiple choice 400 question exam that covers the whole entire field of psychology. You have to do an oral exam, which is you sitting down with a board of already registered psychologists who will ask you a number of questions about your ethics, because we have an ethical code that we have to abide by and understand. And so we sit down and we do an ethics exam. And then another component is that we have to do supervision. So if you're a newly graduate, you're considered a candidate for the register until you click all the boxes. So one of those boxes is to be supervised by a registered psychologist for a number of years. And the number of years has changed over the years. So when I graduated, I had to be supervised for 6 years. Currently, we're supervising for 4 years. So and what supervision means is every month you have to meet with a registered psychologist to talk about the things that you're facing in your practice. So there's always that kind of checks and balances along the way. So you're not just graduating and then this and kind of left to your. There's levels of checks and balances that are in place to ensure that you are practicing ethically with the public. So much like other counselors, however, we abide by it, like I said, an ethical code, and we do informed consent. We provide confidential spaces for people to do whatever we're doing with them. However, we are still bound by the same sorts of things like the Children and Family Services Act, the Professional Health Information Act, Workers' Compensation Act, and so on and so forth. So we are still bound by all of the pieces. And so when we think about the new Regulated Health Professions Act that's coming, I don't know how many people know about that piece, but it's the government in November of 2023 began working on the process of a Regulated Health Professions Act, kind of replacing all the individual acts that each profession already has in place, in addition to allowing self-governance. So our Board of Examiners will continue to be working on policy development and the function of every day kind of the psychologists, but we'll all be under this umbrella of this regulatory Regulated Health Professions Act. And so that helps us move into that world of not being so siloed in our work, which is why this group and the College of Social Workers has been so great in doing this grounding of bringing us all together and having us better understanding others, which is why it's so sad for me that I'm missing today, because I find being live, you get so much from the speakers, but you also get a lot of rich dialogue in the chat. So that I'm not able to be meeting with you today. So psychologists, like I say, a large spectrum of what we do, how we get and what we do, which would be different than counselors or any other counselor that you might be able to access services. There are pieces that are still kind of gatekeeping to ensure that test materials are used by people that have that training. And so when we look at how we diagnose ADHD or cognitive components, so intellectual disabilities, many of the things that have to be done in a certain way in order to access additional funding and supports through government levels, psychologists do that work. So I go into high schools and I try to talk to high school students about becoming a psychologist. But as soon as they hear, okay, so it's this many years after college for graduate school, but then they start hearing, and then you have these things, and then you have those things, it kind of makes them not feel like it's a great trajectory, because they just want to get out and help and work with people. But we do that right away in our graduate training. So we start working for school psychologists in schools right away. So we have people supervising us. We're kind of not left to our own devices. We are working with kids within the first year. And then as soon as you graduate, you begin your practice, but you are supervised. So it's kind of it in a nutshell. But like I say, there are many different ways to become a psychologist, and there's many different specialties that we engage in. So thank you and enjoy the rest of your time together. I will be watching recordings of the session. Grateful as always to be part of it.
I was going to say thank you, Natasha, and she's not here, obviously, but I am really grateful that she was able to provide that video. And thanks to Naj for coordinating this before I started in this role, who did a lot of the initial work and relationship building and supporting folks to be able to contribute content today. So that was Natasha, speaking on behalf of psychology. So already you're starting to hear some of the ways that psychology as a profession can be sort of integrated and connected to other fields for providing better patient care. We're going to move on from Natasha over to, a second here, pardon me, Tara Moore, who is joining us and to speak on behalf of physiotherapy. For this, I'm going to stop sharing my screen so that we can see Tara. Tara, I'm going to kick it over to you.
All right, thank you. I'm actually going to share my screen. So I'll do that now. Here we go. All right. So my name is Tara Moore. I'm a physiotherapist in Nova Scotia, and currently I'm working with the neurology and spinal cord injury team at the Nova Scotia Rehab Center. Apologies if you hear any background noise with the baby crying. They're just in the other room with their dad. So what is physiotherapy? Just to start off. So physiotherapy focuses primarily on movement disorders and works both with rehabilitation and the prevention of disease and disorders. And we utilize a lot of techniques, including exercise, manual therapy, education and advice, modalities, and rehabilitation. So as a physiotherapist, we're a primary care provider who assesses, diagnoses, and treats physical impairment and movement disorders. And our goal is to optimize and restore patients' physical function and well-being. And you may see from the next slide that goes into some maybe examples of different conditions that we treat and we're involved in. It's not necessarily what we treat that defines us, but it's the lens in which we look at it and assess it and kind of approach the situation. So what does a physiotherapist treat? So like I said, we're involved in a lot of different areas. So musculoskeletal injuries, back pain, sprains, sports injuries, neurological disorders like stroke, Parkinson's, multiple sclerosis, to name a few, postoperative recovery and rehabilitation, respiratory conditions like COPD and asthma, cardiovascular issues, including rehabilitation after heart attacks, chronic pain management, as well as injury prevention and overall just health and well-being. Some examples, if you're kind of thinking of how all that information is applied, of when a physiotherapist may be indicated or when physiotherapy may be indicated, is when someone has reduced mobility. So example, someone has a recent spinal cord, you're trying to get them bed to chair, early mobilization in a hospital, post-knee replacement, increasing mobility tolerance after a heart attack with the heart health classes. We're also involved in a lot of pain management, so chronic pain management, such as in low back pain, post-op, acute pain management, or acute injury pain management, such as like a neck sprain from an MVA. Another area of practice, if you're kind of thinking of someone may or may not be appropriate physio, if someone's having balance and falls issues, recent or increased number of falls in elderly populations, someone needs a gait aid for safety, such as in diabetic neuropathies, post-op and post-injury, getting people moving post-op in the acute setting, you'll find us, as well as in the outpatient setting, just that general rehabilitation after injury or surgery. We're also involved in a lot of preventive and conservative management. So if someone's not a surgical candidate for, let's say, a joint replacement or a rotator cuff repair, physiotherapy would be an option for conservative management. As well, we're involved in a lot of pre-op work to help strengthen around the area in the body and trying to kind of kickstart that post-op rehabilitation. We're involved in a lot of education and advice. So one of those areas could be for asthma, for symptom and lifestyle management, as well as just general advice around different areas like pain for low back pain management. Physiotherapy in Nova Scotia, we're found in the public system for these things and the private system. So in the public system, you'll find us in the acute setting, inpatient rehab, outpatient, you'll find us in a lot of clinics, and then as well as in community, whether we're coming into people's home for community physio or we're doing a lot of community programming in the community health books. We're also involved in private practice, so outpatient and in-home physiotherapy options, majorly for those. How would you refer to physio? So we are direct access providers, and what that means is we don't need a doctor's referral for you to come to physio. Although if you're going through insurance, some insurance companies still require you to have one. So if you have someone, just educating them on that piece. Patients can self-refer themselves to physiotherapy in the private and public setting. Doctors can refer, most interprofessional team members can refer as well. Other physiotherapists can refer. So let's say you're an inpatient physio, you're doing outpatient services, you can refer to those or to community services. Sometimes there's kind of a standing or automatic referral that happens in the areas of practice where, for example, at the inpatient rehabilitation setting, if you're coming for rehabilitation, there's kind of an automatic referral for physio if it's warranted with who's coming in. Referral procedures can differ for practice sites, so just being aware of how physiotherapist is referred to in the clinical area that you're working. So sometimes that involves a doctor's written order to go in the chart. Sometimes that involves faxing the referral to the physio department and going from there. On physio referrals, sometimes it gives some information depending on the clinical area on what you're referring them for. And that can give also some insight into if physio is indicated or what kind of some things physio could be indicated for. Looking at barriers for physiotherapy. So public system is covered under MSI, but working in the public system, a lot of barriers can involve funding, especially for equipment, and that can hold up a lot of discharge or progression of physiotherapy, or trying to get them to progress and do things more at home with the most appropriate equipment. Things like the Test Fund, DCS, Red Cross, Easter Seals, and specific diagnosis groups such as the Muscular Dystrophy Society are often used to help with funding for equipment, if appropriate. Waitlist for outpatient services isn't really a financial barrier, but we have high waitlist in Nova Scotia, especially depending if you're out of certain areas and you're in a hospital that does have a high wait list. Then you're waiting for physiotherapy, and your financial barriers, if you're not able to afford private or you don't have insurance for private, that can really come into play, as well as transportation and parking. So the public system, especially in the city, we have the VMB site and the Nova Scotia Rehab site, where parking plays into role and transportation. So if someone's coming to using excessive bus. Private is fee for services, so there is the financial barrier of that fee, whether someone can afford the full fee or they have insurance to cover it. If that insurance covers a percentage of the visit and how many visits that covers, if it completes the rehabilitation plan that the physio and the client has set together. They also can apply for services for funding for equipment. As well, fees can vary for some different practice areas. For example, pelvic floor PT versus going to physiotherapy for more of a musculoskeletal condition, there is sometimes a difference in cost for those and whether that percentage is covered by insurance. How can we help advocate? So communication with physiotherapists, or just being in communication with your team members on your site, or reaching out to individuals who are part of the collaborative team, can really help to kind of address or help identify if physiotherapy is warranted, or if maybe a different avenue is appropriate, or which type of physiotherapy may be warranted, whether sending them to in-home physiotherapy referral or to an outpatient clinic referral. Communication, listening to the patient. So I really like that picture you had with the elephant, because that comes into play. I know patients come in, probably for everyone here, and they come in with a list of things that may or may not be relevant to what you're working on, but just trying to listen to them and see if physiotherapy or a different area of practice like social work or OT could be helpful in educating the patient on those areas in plate and where maybe they could be addressed by different healthcare providers more appropriately. Know the referral protocols or procedures in your clinic area. Educate. If you're telling someone about physiotherapy, you can always say we are a direct access provider. You can self-refer. If they have questions about insurance, getting them to reach out to their insurance provider, and providing resources can be a really helpful tool to advocate. So on this slide here, I just listed some resources. So we have Find a Physio map on the Nova Scotia Physiotherapy website. There's the Nova Scotia Physio Instagram page, where we have some general information about physiotherapy and how we're direct access, as well as just some information about physiotherapy in Nova Scotia. The Nova Scotia Physio Association Facebook page is also an option, as well as the Nova Scotia Physiotherapy website. They have a lot more information on physio in Nova Scotia. Thank you.
Thanks, Tara. Also, I love the content you shared, but the slides were beautiful. Did you
Joe.
make it just for today?
Yeah.
Yeah, it looks gorgeous.
Thank you.
We're going to go back to my sharing of screen, and we have some more content from folks who can't be here, but were really wonderfully pre-recorded. Let me see here, share sound. Pardon me while I just get this set up again. So next we're going to hear from Eva Burrell, who is a social worker, and she will be speaking about the social work profession. So I'm going to go on mute for myself and share this. And again, if you can't hear the sound, please let me know, but it should be set up correctly.
Hi, everyone. Thanks very much for having me. My name is Eva Burrell. I'm a social worker with Nova Scotia Health, and currently my role is as a professional practice coordinator in Central Zone. And so Naj asked me to come here today to speak with you a little bit about the art of collaboration with social work. I think that first and foremost, the important thing for us to address is that social work has a harmful and complicated history with several populations of people in Nova Scotia. And so I would say the biggest thing that you can remember more than anything else is the importance of explaining why you think a social work referral could be helpful and asking people if they're okay with that. So consent is absolutely key if we want to refrain from causing further harm to people who have a harmful history with the profession of social work. Second thing is to have at least a loose understanding of what it is that we can offer. I often describe us as the experts in the invisible. So anything that's sort of process oriented is absolutely something that you can draw upon us for. And I'll get a little bit more concrete in a bit. So our jobs are to address the psychosocial or structural issues that might be impacting a person's health or their care plan. We can be involved in a number of different areas, but in 4 main domains, I would say. Anything around safety or risk to the client or the patient. I would absolutely consider a social work consult. So that could be a question of perhaps an elder in hospital demonstrating difficulty with decision making, unsafe circumstances at home, perhaps exhibiting signs of frailty and risk of falls, lack of supports, and showing that they don't necessarily have a great degree of insight. That would definitely warrant a referral to social work. An even higher level of risk or red flag indicator for us would be if there was any evidence that that person was being taken advantage of or neglected. So any safety issues around capacity or cognitive issues, intimate partner violence, gender-based violence, any evidence of child abuse, absolutely consider consulting a social worker for assessment and safety planning. We're also trained to help people and their families and their care teams navigate the major life transitions that are inherent in having a new diagnosis or any kind of encounter with the healthcare system. So if someone that you're involved with is in crisis, they have a new diagnosis perhaps, or they've been involved in a traumatic incident, I would absolutely consider consulting a social worker. Lots of people will learn about the news of the end of their life and have a very normal grief response to that. We don't need to be involved in every person's grief process. But if you're seeing that there's a high level of distress, that people are having difficulty taking in their diagnosis and prognosis, that they're making decisions that you're concerned about, or maybe that family members aren't understanding, absolutely involve us, or if there's a high level of anticipatory grief. We also help a lot with systems navigation. So I'm sure you all know we have very complicated systems, and many people involved in the health system who are involved with numerous different systems, whether that be community services, or corrections. And so we sort of help to navigate all of the different pieces of the health system and the other systems and case manage to help people get the best care that they require. And then we also help address the practical concerns like medication coverage, ability to pay for transportation to get to treatment, dialysis, whether or not people have insurance, all those sorts of things that we can absolutely help with. The best thing to do, besides making sure you're getting informed consent for social work involvement, is, I would say, to take a detailed social history. So many people would benefit from social work involvement, but if we are tied up with doing assessments and screens to determine whether or not people do actually need our service in that level of acuity or in that service, that actually takes a lot of really precious time. So if you are able to ask questions about things like their community access, if they can get to appointments, and to normalize those questions, saying things like, you know, a lot of people, given the economy, are having a really hard time making ends meet. I'm wondering, if we prescribe you some new medications, are you going to have any issues paying for those? How would you typically manage that? I'm asking you because I want to make sure that we get you connected to everything you need. And even just opening that door with people a little bit typically opens the possibility for them that they can trust you to talk about the context of their lives beyond the immediate medical condition. And that is probably the best thing you can do to improve their experience with the healthcare system, their health outcomes, and determining whether or not you need to appropriately access social work. Thank you very much, and I'm really, really excited to think about so many people being interested in thinking about how to better collaborate with one another to improve patient care outcomes.
So much gratitude to Eva for providing that content. And it's funny sitting here as a social worker watching that video from her. I'm like, I learned quite a few things myself. So no shortage of new knowledge to be shared in these series. We are going to continue on, and we are going to pass it over to Emily. So Emily, I'm going to stop sharing screen and allow you to take over. And so Emily's going to be speaking on behalf of Recreation Therapy.
Awesome. Hello, my name is Emily Flynn. I don't have a presentation, so you're stuck with me and potentially my two cats that really like to be a part of Zoom. So my name's Emily Flynn. I'm a certified therapeutic recreation specialist. So what that means is I completed my undergrad degree. I received Bachelor of Science in Therapeutic Recreation, and then I wrote my certification exam through NCTRC and maintained that through continuing education. So the first thing is, what is recreation therapy? Some people may have had the pleasure to be able to work with a rec therapist before. So there's recreation, therapeutic recreation specialists, there's recreation therapy associates, and then there's therapeutic assistants as well. So what recreation therapy is essentially it's using recreation and leisure as a form of therapy to improve one's overall well-being. So that's very broad, and it looks very different in many different settings that we work in. We work in hospitals, long-term care facilities, community, group homes, really anywhere can benefit from recreation therapy. We are not licensed currently, but we are working hard to do that. So right now I am part of our provincial association on our board of directors. I also work at the IWK Children's Hospital in Community Mental Health and Addictions, and I'm the professional practice leader for recreation therapy at the IWK. So we really use a lot of different interventions, but all surrounding recreation and leisure. It really depends on the population that we're working with and the setting on what those interventions will look like. But a huge part of our role is that interprofessional collaboration. People always ask, when should we refer to a rec therapist? As soon as possible. So from my experience in the past, I've worked a lot with OTs, a lot with physiotherapists. In my job right now in community mental health, I work a lot with our OTs, social workers, and psychologists, along with the psychiatrists as well. So one example of how you could refer to us and what I've done in the past, I worked with one older adult with a developmental disability who is nonverbal, and they were prescribed physiotherapy exercises in the form of like arm extensions. So we had the physiotherapy recommended exercises, and with that, we adapted it to be doing like basketball, and we did some air hockey. So we used recreation and leisure to help support the other individuals' interventions as well. We'll get a lot, I've done a lot of work in small option homes and residential care facilities where we'll have doctors, recommend some weight loss or increase in activity, and we do that through recreation and leisure. So again, like a lot of sport, a lot of outdoor walks, maybe we make it a little bit fun. Right now with my work with community mental health and addictions, how we're referred is because we're not licensed, we have their main primary clinician who's either an OT, social worker, or psychologist. They might be developing the skills with the youth or child or family. Maybe it's surrounding low mood, maybe it is OCD, maybe it is bipolar, early psychosis. They give them all the skills. And then what they noticed over the last couple years is that they were giving the families these skills. They were able to use it, but they weren't necessarily using it out in the community. So if someone, maybe they give them some a step ladder, or maybe some coping skills, or maybe to practice some social interactions. And they have the skills, but they have nowhere to actually practice them. So that's when they'll bring in the recreation therapist, and I'll set my own goals based on recreation and leisure and go out in the community and do that with them. So maybe their primary clinician gave them all the skills for social interactions, but they aren't part of anything in their community and don't know how to practice that. So part of my job is to actually meet the individual where they are, set person-centered goals, and do that with them, because that actually came out from feedback from the youth and families that they were like, this service is fabulous. However, once we get home, we don't really know where to use them. So that's where recreation therapists came in. In terms of my role as the professional practice leader for rec therapy at the IWK, I'm consulted in on any scope of practice questions, along with sitting on committees that might necessarily not have anything to do with recreation therapy, but I'm able to add the lens in from that scope and my background. Like I said, it's very different in many different places. I will say I've worked many jobs where there was never a recreation therapist before, and I created the role when I was there. And the best thing I did was just lunch and learns, meeting with the team, explaining what I do. I always had a bulletin board outside my office of who I am, what I do, how you can use me, to make sure that any person from the interdisciplinary team understands how they can use me and how I can be beneficial. In terms of private practice, we don't have many recreation therapists who are privately, but I will say that if you're in an organization and you're like, wow, we would benefit from a rec therapist, you probably will. We are a great profession, but you can always reach out to our provincial association, so NSTRA. If you reach out, I would be the person that you contact. But if you're saying like, this is where we work, this is the population, I really think we could benefit from having a recreation therapist. How can I go about approaching my manager? How can I put in a proposal for your job? We have a whole advocacy committee. We would definitely be happy to help. And like I said, the earlier you can bring us in, the more beneficial for the clients and the patients you serve can be. And that's all.
Thanks, Emily. I'm
No
just reflecting
problem.
as you're speaking about how many people have complicated relationships with sports and recreation and leisure, and how recreation therapy probably serves a really valuable intervention point for folks. Being able to connect into play and
Mhm.
fun in
And
their
it's huge
bodies.
too, like, especially after COVID, where everyone was
Mm,
isolated for so many years. A lot of the youth that I work with are like, I don't know what to do in my community. I'm bored all the time. Or they're like,
mm,
I don't like playing sports. What else is there? And we look at art programs or independent leisure,
mhm,
and yeah, it's super
mm.
cool.
Well, thank you for sharing, Emily. I really
Yeah,
appreciate that. And also,
thank
I have this
you.
feeling that you could just speak anywhere at any time.
Thank you.
So it was fun to witness. I'm gonna go back to sharing my screen here, and we have two more clinicians who will be sharing pre-recorded content. As I get set back up here. So we're going to move next to a conversation between Naj, actually, who's on this call with us today and who was in the role before me. And they were speaking with Kirsten Wells, who is a chaplain, I believe, and also specializes in clinical spiritual care. And so this is not a direct presentation, it's somewhat of a conversation. So we're getting the opportunity to witness a little bit of magic happen between two people here. So I'm going to click this and go on mute, and we'll get into this video.
Hi, everybody. My name is Kirsten Wells, and I'm a certified spiritual care specialist with the Canadian Association of Spiritual Care, a healthcare chaplain. I've worked in patients for most of my career, and now I'm in a community team. So I'm going to just share my thoughts about appropriate referrals to spiritual care, and when I refer out to other clinicians. So in talking with Naj a bit, getting ready for this, I was reflecting on something that came up when I was working in patients, when the chaplains were thinking, why is it that we're not getting a lot of referrals from the inpatient units or information even on patients' spiritual needs? And our one of our staff looked into how the general assessments go for the inpatient units and discovered that the question about spiritual care needs read something like, do you have any religious and or cultural concerns that the team should be aware of? And it was right beside the question about, do you engage in regular breast or genital self-exams? And it was at the end of the assessment. And routinely, these two questions were never filled out because people were very uncomfortable. Whoever was conducting the assessment was uncomfortable asking about both of those topics. You've got God and sex right there at the end of the assessment. So that became clear that assessment needed to be rejigged in terms of the order, because spiritual care, both those things are important, but the spiritual care question also was not that relevant. To ask about concerns kind of leads people down the sort of death phobia pathway. And in our culture, if you ask someone if they want the priest, instantaneously, they think they will be dying very, very soon. And the solution to that is not to call the priest. And this unconscious belief and association is extremely strong in our culture. And I'm using the priest as a Christian example, but could be rabbi, imam, shaman, whoever. There's no one faith group that has a monopoly on this death phobia. So in healthcare, people are anxious already. Something very serious is happening. And when a staff member who isn't a spiritual care provider asks them about their needs, it's really essential to figure out, how do I get a true answer from this person without triggering their fear, which is already activated? So some better questions could be things like, do you have any worries or fears about what's going to happen to you while you're here? would you benefit from having someone to talk to about your worries or anxieties, or even having someone come by as a resource and a support? These kind of words don't trigger the death phobia, but do communicate that a trained spiritual care provider can be a very useful tool for exploring anxieties, fear, grief. Often patients have extremely complex grief coming into an admission, and that can be triggered and even exacerbated by what they're personally going through in the hospital. So people may not think to say, you know, have you lost people in your life recently? And recently could be the last 10 years, could be 15 or 20 years, depending on how the person has dealt with their grief. But that often comes up during a hospital admission. So how you ask the question about someone's spiritual care needs is really important. And if you happen to be working with the chaplain, having that conversation about how can I best get at the right question would be a useful conversation to have. Currently, I work on a team with respiratory therapists and social workers, and we routinely bounce patients back and forth between us depending on our scope of practice. So generally, you know, from a spiritual care lens, I will explore anxiety, worthiness, issues of life, death anxiety, death phobia, and basically what I provide is advanced care planning, which is a direct conversation about planning for our deaths. And many people are stressed about the conversation. They bring up all kinds of things during the conversation, like near-death experiences, lack of near-death experiences, the beliefs about whether there's an afterlife or whether there isn't, how that influences how they're living today. And we come up with a really robust plan for their best plan for their exit from this life. And at the end, people routinely say, I am so relieved that we had this conversation. It lets off a lot of pressure that has been building up inside a person because they haven't had the opportunity or the vocabulary to express their worries. And the conversation is framed around beliefs and values. So if you're working with a patient and you hear beliefs and values coming up, that's a flag that maybe spiritual care could be a useful tool to use in supporting that person, because people come into the hospital with all kinds of beliefs and values about whether they're going to get better, whether they're worthy to get better, whether they trust their clinicians, whether they trust their God, all kinds of things. And when that's all buzzing around in someone's head, it directly can impair their ability to recover from physical injury, illness, even chronic disease. All these things we know influence the immune system. So it's really important to gently create a space where if they have the courage to wade in there, they can release some of that steam that has been building up inside them with someone who can handle the conversation in a way that doesn't scare. We're prepared for the content. Because it's interesting how often in healthcare, all of us are trained and have worked with people who are dying or have died. But a lot of our staff have never been trained on how to talk to people about death. So it's something that happens every day. We all help people through it. But talking about it can be really challenging for some people. And over the years, I've noticed with some of my colleagues, there's a lot of anxiety about consulting with spiritual care because we're probably going to bring up death, and that will upset the patient. And so that's a really interesting belief that we as allied health providers may carry within ourselves. And that may influence whether or not you choose to refer or call in or consult with a spiritual care provider. So it's so interesting to think, not only does this work apply to how we talk to our patients, but also a little self-reflection about where we're coming from on this spectrum, because we've all been influenced by our culture. So currently in my work, social work, spiritual care, respiratory therapists, we go back and forth depending on the patient needs. And it's so interesting because after a patient works with a respiratory therapist, they get all kinds of education about breathing and breathing devices and medication. Then they come to me. We talk about a lot of spiritual care things. We talk about behavior change, beliefs and values, advanced care planning. And then we have a social worker on our team who specifically addresses addictions, nicotine, alcohol, all kinds of things like that. And once a patient has worked with one of us and comes to the next one, it's almost like the work from the first person kind of distills, and then they think, oh, right, maybe I could go a little deeper with that person. So I'll often say, oh, I'm going to send you back to the respiratory therapist just to cover this extra little bit. Then they may come back to me when we're done working, or if their need to quit smoking, for example, is higher than their need for advanced care planning, I'll shoot them over to the social worker. He will deal with that emerging need and often refer back to me. So in an ideal state, that's what we would love to see, that we're all involved with our patients and we have this nice fluid patient-centered plan so that what the patient needs is what they get and they can move back and forth between all of us. So those are my rambling pre-recorded thoughts for this panel today. I hope it's been helpful for you, and thank you very much for your time.
Grateful for Kirsten's words and perspectives and insights to clinical spiritual care and chaplaincy. And I thinking back to the land acknowledgement and this idea of decolonization, and a particular view that I hold is that colonization has led to a deficit in spiritual awareness and understanding, and how that is interconnected to our physical and mental and health. So it's really grateful to hear those words from Kirsten, and I'm grateful that they could be with us today. And thanks to Naj for setting that up. Thanks to Naj for setting up all these speakers, actually. We're going to keep going with our final speaker, Amelia Fletcher, who is speaking on behalf of occupational therapy. And then it's just a reminder that, you are welcome to leave at any time. I see some folks have to leave, it's now after 1 o'clock. This is scheduled to go to 1:30, but, trust that you folks know what's best for you. But also encourage you to ask some questions in the chat or in the Q&A if you feel is bubbling up. And again, we might not be able to answer them today, but we can try to. And if they don't get addressed today, maybe they'll lead towards future PD opportunities. So we're going to hear from Amelia Fletcher speaking on behalf of occupational therapy.
Hi everyone, my name is Amelia Fletcher. I am an occupational therapist with the Nova Scotia Health Authority. I'm currently working in the Mental Health and Addictions program at the Central Zone Acute Mental Health Day Hospital. So it is a group-based program for adults living with severe and persistent mental illness. It can be considered a step-down program from inpatient psychiatry, and it can also prevent admission if somebody's becoming acutely unwell in community and they just need a little extra support. We operate 5 days a week. We have a call phone on the weekends, and we offer psychosocial programming from a recovery-oriented approach. And I work as part of a multidisciplinary team, which I know is kind of what these collaborative care practice seminars are related to. So the team here at Day Hospital is myself, an occupational therapist. We have a rec therapist. We have 2 social workers. We have a nursing team, psychiatry, and clinical therapy. I think that's everybody. So we collaborate here to provide psychiatric patient care. And I have previously also worked in inpatient psychiatry and outpatient psychiatry as well in my OT role. For those of you who maybe haven't worked with occupational therapists before or are unclear on the role that we can play in multidisciplinary teams, we focus on function. So regardless of diagnosis, occupational therapists' role is to assess and promote, or to assess function and promote participation in meaningful activity. So occupations, are kind of the name of the game for us. So occupations are the things that we do all day that bring our life meaning, that create a sense of productivity or connection with community. It can also include things like self-care, hygiene, meal preparation, community navigation, transfers, going to work, volunteering, going to school, participating in relationships. So we support people in building the skills that they need to participate in what's meaningful to them. Sometimes that looks like grading activities. Sometimes that looks like recommending accommodations. It might include adaptive equipment, or it might include advocating with community partners, employers, and schools to create more inclusive environments. So occupational therapists work in a variety of practice roles, both in Nova Scotia Health and the public healthcare system. Privately, we can be found working in schools, in nursing homes, in prisons, community organizations, kind of anywhere I guess that you would find most other healthcare providers, but there's also a role for us in community organizations as well. Many OTs work in kind of inclusive design, in advocating for more inclusive environments from a sensory perspective, from an ergonomic perspective, from a psychologically safe perspective. So you can usually find us just about anywhere. And as an occupational therapist, I really value the role that I have working with a multidisciplinary team. One of my favorite things about working on a multidisciplinary team is that when I don't know the answer, I know that someone else does. And I feel that it's a really excellent way to provide patient care or client care. And I really value the team that I work with here at Day Hospital. If anyone has any questions, I know this is just a recording, but my email is amelia.fletcher@novascotiahealth.ca. I'm happy to take questions at any time, and I hope you enjoy the rest of this care practice. And I'm sorry I wasn't able to join in person. Have a good day.
So grateful to Amelia for pre-recording that content. I was just jotting some notes down. I'm listening here to the folks who spoke today. I'm thinking like there's sort of 4 through lines that are kind of coming up for me as I hear the folks speaking. Firstly, the diversity in practice, context, and scenarios. So everyone who's spoken today has spoken about a multitude of ways that their profession can intervene, which I think is really interesting. Also, there's an ever-changing landscape. So for all of the folks who've spoken today, you know, the context we find ourselves is changing all the time, and it's also complex. And then finally, just, you know, that importance of collaboration and working across different professions is really bubbling up for folks. We'll just see a note here. I've worked with Amelia on an inpatient unit before. She's very dedicated and great to collaborate with. And so someone who's on the call has talked about how great it is to work with Amelia. So thanks for saying that. So a reminder, you know, there's only a few of us on this call as panelists, but we can answer some questions if you have any that are bubbling up for you. So I'll just give folks a few seconds to think if they have any questions. No pressure though. While maybe people are thinking about questions, I'm wondering, Emily or Tara, anything bubbling up for you folks as you've listened to the speakers today?
Nothing necessarily bubbling up. I think this overall panel and webinar really highlights the importance of every profession understanding other professions as well, and how collaborating with the appropriate profession and individuals can really help one's overall care for a patient.
See, a question has come in, and so I'm going to read it out, and this is open to anyone. So either of you, if you'd like to speak on it. So as a social worker who has always practiced outside the healthcare system, I've always struggled with issues of client consent and information sharing, which are essential to do good collaborative planning for and with folks. Are you aware of any innovations in simplifying this so that we can keep the person at the center and keep our organizational rules and organizational directives from getting in the way? The background. So this idea that to work collaboratively, that story of the client and the patient, is so essential. And so how do we avoid maybe making them have to retell their story all the time? Or how can we work across our different risk mindsets that exist within our profession? Emily, Tara, any thoughts on that?
I know within the IWK with community mental health, we use the term, I think it's an example of like a bus stop. So the person who we're supporting and their family gets on at the beginning. So when they call central referral for support, that's kind of their first bus stop. And then they go through many different bus stops along the way. And what we talk about is that they shouldn't have to reshare their story at every bus stop. It's up to us as clinicians to make sure that we have that information. So it's within our policy where we work that we are the circle of care team is what we use the term. And we actually include that in our consent when we get the client and families to sign consent. They're agreeing that their information can be shared within the circle of care at the IWK. Now, for myself, sometimes I have to fill out like registration forms for people or outside agencies in the community. For that, we have a policy that's called I think it's like sharing of information or something, essentially where like my email has IWK in it. That's almost outing if I email anyone outside the IWK. So the individual is able to sign like, yes, I want you to contact this person and this is what you can tell them. Because they might not be comfortable sharing that, or maybe they've told it a bunch of times and they don't have to share it again. So I guess the easiest way can be like looking at your policies, seeing what your policy says, and then if you're having issues that's actually, hindering care, maybe propose another policy or a workaround.
Thank you for that, Emily. Yeah, it reminds me of like how much risk mindset and is pervasive in the work that we do, and how risk and liability are often centered before the care of service users, clients, and patients. I know I've worked with an organization down in Digby that was providing care for youth, and they would have police officers, doctors, nurses, social workers, psychologists, a whole bunch of folks around the youth. And one thing they did was similar to what you addressed, was like sort of like a central intake point that was, what information can we agree upon that can be shared within this circle of support. But I'm curious to see what kind of innovations might come out still. Just seeing a note from Tara that she has to feed a newborn baby. So thank you so much, Tara, for being here. Also just going to look through the chat here quickly. Seeing someone, someone within the NSHA is saying that we asked for a release of information form that outside agencies and individuals can be contacted. Right. And also seeing, I think we need a network of collaborative interdisciplinary primary healthcare centers, pardon me, that includes the provision of mental health and addiction services. Why, when we have 160,000 people on the need for a family doctor list, don't we act on this? Yeah, I think when we're holding on to these questions and critiques of the current system, we have to recognize that there are just so many barriers built up over generations and time, and so we have to innovate, we have to get creative, we have to do things that sort of challenge that scarcity and risk mindset, and it can be so hard in our systems that are so entrenched. I'm wondering if there's any other questions from folks. Well, I will take this time to say that much appreciation to you, Emily, for being here, and for Tara as well, and also to Amelia and Kirsten and Eva, and forgetting someone, Natasha. So the 6 folks that were with us today to share their perspectives on collaborative care and also give insights into their own profession. Again, this is just part of one part of an ongoing series. So please look to our website or in our YouTube channel and our newsletter and social media feeds to see about upcoming activities. If you don't follow us on Eventbrite, please do. That's a great way to stay abreast and on top of the different PD opportunities we have. Again, reach out to me, tyler.colbourne@nscsw.org at any time if you have questions or thoughts around professional development. I'm going to stop recording, and I'm going to say goodbye to folks and hop off the call whenever you'd like. And thank you so much for spending time with us on this Friday. And I hope that you're finding things to do with the rest of your summer, things that bring you joy.